Hello, I'm Antoni Chan. I'm consultant rheumatologist in the United Kingdom and reporting here at EULAR 2022 in Copenhagen. One of the big advances that we've seen, especially after the COVID-19 pandemic, is the use of digital health applications, DHAs. And this has really taken a big step forward as we rethink the whole management of our patients with rheumatic diseases. And I'm very delighted that I'm joined by Johannes Knitza. He's from the University of Erlangen in Germany, and he's been doing a lot of work in the field of digital technologies and digital health. And so we're very happy that he can join us tonight to share some insights of some of the work that he has presented at EULAR 2022, some really novel work. So Johannes, welcome to this discussion tonight.
Thank you so much for the invitation, Antoni.
One of the work that the posters you presented, it's poster 1545. I was very interested in your work because you use some very novel ways of using capillary blood sampling and also looked at CRP, rheumatoid factor, CCP in the field of rheumatoid arthritis. Now, we wouldn't have thought small blood samples like this could identify such important biomarkers. Could you tell us a little bit more about the work that you have done?
Yes, absolutely. So maybe to introduce this work, I've been doing a lot of research on symptom checkers where patients put their symptoms in and then they get quick information if it's likely that they have an inflammatory rheumatic disease or not. And I found out that these tools are somewhat nice because they allow some information within minutes. However, the accuracy is very limited at the moment. And I thought laboratory parameters such as antibodies, CRP, will improve this accuracy. And for monitoring the situation is similar. In my opinion, we have electronic patient-reported outcomes and validated questionnaires that allow tight monitoring. However, I also believe that the laboratory parameters and especially inflammatory markers really might improve the current monitoring approach. And so I wanted to have a look if patients can actually on their own draw blood. And I mean, if we think about this is very known already in diabetes, where patients continuously measure their glucose levels and otherwise on the upper arm. And then there's also the traditional approach at the fingertip, this finger pricking. And so the main goal for me was to find out which approach might be, if it's working in RA, if it's accurate, if it's feasible, and which of these two approaches, so upper arm-based self-sampling and finger pricking, which one is more accepted by patients really.
And what did you find in your study in terms of the two techniques?
Yeah, so I wanted to make it nice. So I did a randomized controlled trial and basically randomized seropositive RA patients, so with rheumatoid factor or CCP antibodies, to one of these two devices, so to conventional finger pricking or upper arm-based device called TASO. And then I really wanted to add if it's accurate. And so we found it's excellent for rheumatoid factor, CCP, and also for CRP. And then it's also really, we found high usability for both devices. However, we could really find out that the upper arm device is a lot more accepted by patients. So we used the Net Promoter Score, and for the finger prick, it was actually negative, so -20. And for the upper arm, it was positive of 28. And so maybe more easy, we asked the patients which one of these devices would they be willing to use at home to draw blood, and 60% in the upper arm device group said, yeah, I would actually do this, and only 32%, so half, would use the finger prick approach. And so this really motivated me to do more studies with these upper arm devices, for example, to monitor COVID antibodies so that the patients don't have to come in to see if a next vaccination might be needed or not, but also for diagnosis, for SBA, for example, for HLA-B27. We're having a look into this, and of course for vasculitis, lupus, and yeah.
That will be better and more convenient, and I suppose quicker way to be able to diagnose patients. So did they send the samples to a lab? Did they take a sample from the arm or the finger, and was it then sent to a lab for analysis, or did they do it in their home? Was this a near patient test, or was it sent to a laboratory?
So I really wanted to start in a really safe environment. And I didn't say this. We also wanted to compare to the current gold standard to venous blood collection. So we did it in the hospital, and we supervised the patients there to avoid any serious injury. So it was really a first step and a major result, which is also important. Both devices were significantly less painful than conventional venous blood collection. But then, yes, the patients did this, the blood collection on their own, and then we compared it to the professional venous blood collection. And then the samples were shipped with normal postage to laboratory. We did this in cooperation with Thermo Fisher, which ran the analysis.
And your correlation was very high. I think you almost got to one, near one, in terms of the sample, the capillary sample, and the laboratory sample. So high levels of accuracy there. So where do you think, in terms of this going forward, where would you see this being applied, most in sort of clinical practice?
Yes. So I see two use cases. So maybe to go back to the beginning. So in terms of diagnosis, in Germany, it's quite popular actually to get a first consultation like us now, a video consultation. And then, I mean, for some patients, if I see, for example, a swollen joint, and the patient already told me, or if it's not a patient yet, he wants to check the symptoms and maybe has a positive family history, then I think it might be useful if these patients get one of these devices at home and can check if I have CCP antibodies or rheumatoid factor. And to be honest, then I think the diagnosis is quite easy. And I think for example, AxSpA, this is very similar. Yeah? And so this is what I think could happen for diagnosis. And for example, for monitoring, I think currently we can sort of have a snapshot approach. Also, Christian De Jaco mentioned this in his telemedicine session. And he said with telemedicine, we can really make a film where we really avoid this black box approach. And for example, for autoinflammation patients, CRB would be very useful to see if there were flares, also for patients to really get quick feedback, and for us to gain important data for our treatment decisions. So I think these use cases, and of course for COVID antibodies, in terms of vaccination, and maybe even for immune globulins, like for patients under rituximab, I think this might be quite interesting. And of course also for prediction of flares in the future and measuring of drug levels. So this is where the most evidence is at the moment. So for hydroxychloroquine, there has been a study with capillary blood. So I think there are quite many use cases for this.
Excellent. I think we can select the the outcome or the target, but what you are providing here is the ability, as you say, not a snapshot, but a more continuous way of monitoring patients, because we do know that the CRP can fluctuate. So on one day when they come to clinic, they can look quite well, but within a few weeks, the CRP might go up. So before they get to that stage, what you're providing is a more continuous way of monitoring. So going back to your analogy of diabetes, where they have a device in their arm and they're having a tight monitoring. And it might be, I suppose, for a good way of thinking about a more treatment to target type approach as the kind of wider picture. You also mentioned about EPROMs or EPROs because that's also something you have done. How do you see this combined with blood tests? What's your take?
Yes, I think so. Sort of EPROs, so electronic questionnaires, really, I think this is the, so to say, low-hanging fruit in terms of digitalization. And I think this should be done very, very quick. And again, yeah, to get more objective parameters. Also, we get this easily from wearables. How are our patients, if they're physically active or not? But of course, CRP would be very useful. And for me, AXPA would be the perfect case. And I'm currently running 2 studies where we now give AXPA patients these kits for home usage. So basically give them these kits, and then if they think, okay, there might be flare, then they use these kits. And also at predefined time points, they do the CRP, they do the electronic questionnaires, and then we have really, for the first time, to my knowledge, the current gold standard, the ASTA's CRP. But the patient is at home. He doesn't need to travel 200 kilometers to get assessed. And then we call the patient, and then we can discuss the results. We can decide if there's a need to actually physically come in, or maybe if it's fine, and we can just send them the new prescription.
I think that it provides a lot of safety and also provides a lot of assurance for patients, but at the same time, the convenience not to have to travel, as you say, a long way to hospital when there is really no need, but at the same time, providing that that assurance for both the patient and the clinician. And you also had another poster which is also looking at this, where you did a bit of shared decision making, and you felt that in the intervention group where you had agreed outcome, agreed patient-reported outcome, they did better than the people who weren't in the intervention group. So, how does all of this fit with in terms of the patient engagement or the patient interaction? Does this improve the communication between the rheumatologist and the patient, or is this extra work for everybody? What's your take on it from your study?
It's a good question, of course. So, to be honest, in this study I presented, it was extra work at least for the VRM patients. So they had to fill in electronic patient-reported outcomes. But I think in the end it was a win-win for patients and for me. Because I was not left with this black box, what happened in the last 3 months, and it completely changed my clinical routine. So now when a patient comes in for a follow-up visit, then I turn my screen around, and then we can have a look together at the last 3 months. And the patients tell me they also really like this, because it's much more easy to tell me what happened in between. And otherwise, there might have been a couple of flares, but the patient now has no more swollen joints. And then it's sometimes also uncomfortable for patients because there is nothing going on. And then they have these flares documented and can actually show this to me. And what was really about this study was that together with the patients, we defined a very clear treatment goal in terms of EPROs for the next visit, so in 3 months. And this was then visible also in the patient dashboard, also with colors. And this way patients felt, or that's actually what they explained to me. We did a qualitative study here, which will hopefully be out soon as well. But yeah, this makes this whole shared decision making maybe more feasible, yeah, as well.
Yeah, I think I like the fact that you agreed at the outcome, because each patient will have an individual, specific outcome for them, rather than we have guidelines, obviously, but sometimes these may not be realistic or achievable for some of our patients. But having an individual outcome like this might be the way forward. I think you talked about rate, less than 4, for example, is one example in your poster. And I think that individualization can be very beneficial for the patient. So we can use this to escalate treatment, so in terms of treatment to target. But I think there's also the idea of dose reduction or dose optimization, where we might actually reduce their treatment in the longer term, just to, if they are doing well. But this system might provide you the information to do that. Do you see this as also on sort of on the other side of the pathway, where you are, once they get into remission, in order to keep them into remission, you might actually dose reduce or dose optimize?
Absolutely, yeah. So I think, I always feel not so comfortable to reduce dosage if I don't really know what happened in the last 6 months, and having access to this data, really seeing that there were no flares, patients didn't use, I don't know, NSAIDs or steroids, I think would make me feel a lot more comfortable. And also it would be, then I could react probably quicker. Yeah? If I get a notification, okay, my patient flares now, I can tell him, hey, please take some NSAIDs, please start using your biological more frequent again.
I think it's amazing. I think this adds to the whole ability to manage our patient in a virtual way. We talk about telemedicine, but it's beyond just the video, like us talking here. There's a whole other technologies behind this, the EPROs, the remote blood tests. A lot of these are the things to help guide the decisions that we make. And the other thing you talked about is therapeutic drug monitoring. We haven't even touched that, because that would be another aspect in terms of trying to dose optimize in our patient. So where do we go from here, Johannes? We've talked a lot tonight about digital. Where do we think we'll go from there with all these technologies? What would be, the things that we would want to solve next? What's your take?
I think the main barrier currently is interoperability. So I have to use multiple systems now to operate this, and I think it would make it a lot more easy for me if systems would speak with each other, and if all the documents come in one system. And this, at least in Germany, at least for me, this is not in the near future. But I think maybe you're in the NHS or at Reading, at your site, this is already clinical routine. So I was really impressed when you told me about this.
Yeah, so I think the integration and the interoperability is important, but also in your study, the interaction with the patient is also important in terms of the engagement and the buy-in. We can keep talking about digital, Johannes. It's always a pleasure to talk to you and sort of see all the thinking and the advances that you're making. So I thank you for your time and also for increasing our knowledge in the field of digital here at EULA 2022. And we really look forward to your endeavors and your work, so that we could advance our knowledge in this area. So thank you for your time, and I hope you did enjoy EULA 2022.
Thank you. Yeah, absolutely. See you.
Bye-bye.